Good afternoon, everyone. We are here today to talk about a very common problem that most of us have come across at some point in our life. So, we are going to talk about abnormal uterine bleeding. I'm Dr. Bhavna Mishra. I'm a senior consultant in the Department of Obstetrics and Gynecology at Aster RV Hospital. And
Hi, I am Dr. Sri Bharati, gynecologist, part of the OBG department at Aster RV Hospital.
So now, when we talk about abnormal uterine bleeding, we must first understand what is normal. Because many times we overestimate our problem and we come to the hospital. So to tell you what is normal, any bleeding which is generally between the 28th to the 30 days interval, which happens for about 3 to 7 days uh, of bleeding, of menstrual bleeding, is normal. Now, but there is a range to say that any bleeding between 24 days of you know to 34 days of your month is normal. So if your periods come every 24 days, it is still normal. Till about 34 days every month is normal. Beyond this, generally there is a reason to it. Now coming to the volume of bleeding. So any bleeding between 3 to 7 days is normal, and for most of them it is for 4 to 5 days in a month. If you are changing your if you need to change your pad every 2 to 3 hours and it's getting soaked, or if the it is soaking through your clothes in the nights, you have to get up many a times to change your pads, or you pass clots which are big in size, bigger than the size of a coin, then generally you are having a heavy menstrual bleed. Earlier on, there were terms which were very confusing, like menorrhagia, metrorrhagia. So these are all now, given away, and we have a more scientific term called abnormal uterine bleeding. Also, bleeding between your periods is abnormal. So, bleeding between your periods, generally at the time of ovulation, that is when the egg releases, there may be a little spot or one day of bleeding, which is still normal. But if it happens more frequently than that, or more erratically than that, or if you have some kind of a bleeding after a sexual contact, say, it is abnormal. And this is time, if you think that your kind of pattern is following the abnormal thing, you must come and see a doctor. Now, these problems are common in throughout a woman's life, let's say. So, from the time she attains puberty in the adolescent age group, the second would be the reproductive age group, when she is going through her family problems until she is about 40, 45, and then starts the period of perimenopause and menopause, wherein also you can have abnormal uterine bleeding. Now, I think I will invite Dr. Sribhati to speak about the problem in the adolescence age group.
Thank you, ma'am. As what ma'am has told, the causes of abnormal uterine bleeding can be divided for the purpose of discussion according to the age group of the patient. Now, to start with adolescent or teenagers, the first 2 to 3 years after the girl attains menarche or puberty, we expect to have some irregular cycles or some prolonged heavy menstrual bleeding in these 2 years. This is because there is a certain time required for the maturation of the hormonal axis
Yes.
in this pubertal girl. So until this happens, we can expect some cycle irregularities. However, when do we know it's abnormal? Like if there is persistence of these heavy or irregular cycles beyond 2 to 3 years, or if the blood loss is so severe that she develops anemia, requires blood transfusion, then we need to evaluate such a girl for any abnormalities.
Right.
Now, some of the common causes for puberty menorrhagia, that is heavy menstrual bleeding in an adolescent girl,
Adolescent.
is thyroid disorders. It could be either hypo or hyperthyroidism. More common entity is the hypothyroidism. Now, this can be easily diagnosed with a simple blood test, that is the thyroid function test, and the treatment is just as simple thyroxine supplementation. There are some rare entities also, like defective clotting, blood clotting factors in the puberty girl, and there could be a low platelet count. Now, these may manifest most often in girls as prolonged puberty menorrhagia, prolonged menstrual flow.
Before that, also before she attains puberty, she may have some kind
Yeah.
of bleeding gums or some bigger clots and all that forming. So you will know in general that she has a problem with
If there is
clotting.
any deficient
Yeah.
clotting factors
Right.
developmentally
Or
in her.
wound just go on bleeding for a long time.
Yeah.
So parents have an idea.
Yeah.
If it manifests at adolescence, then we have to do this little test and come to know.
Usually, we would have to run a blood investigation panel, maybe consult a hematologist. This is the suspected cause. But fortunately, it's quite a rare cause to be leading to a menstrual blood loss. We don't encounter it that frequently in our general practice.
Yeah. So if your adolescent child is say bleeding for about 6 to 7 days and the cycle is a little erratic, don't lose heart. You don't really have to come running to a doctor. Make sure that her thyroids are normal, thyroid function is normal, and then if she is turning anemic, then you have to take care. Give her good nutritious food and make sure that anemia doesn't set in. Beyond that, if you have any concern, please get her to the doctor.
Evaluated by a gynecologist.
Evaluate. Now, the most common, time when the ladies present to us is, of course, the reproductive age group. Um, I think before, we can also talk about polycystic ovaries.
Polycystic ovary.
Yeah, in the late teenage girls, generally, I think Dr. Bharti let her explain what is polycystic ovaries, which also continues into the reproductive age group.
Yeah.
So let's talk about.
So many people would have heard of this entity called PCOS or
PCOS.
Polycystic Ovarian Syndrome. So it may present, in your late teenage years or in your early 20s, 30s reproductive age group. It is a disorder of ovulation. That is a condition where there is an ovulation. There is a disordered egg release in the woman's body. So it's a state of hormonal imbalance. It usually presents with irregular, delayed cycles which are painless and there is scanty blood flow. Normally, these women are slightly on the overweight or the obese side, and if they are young married couples, they may come to us with infertility.
Yeah, and there are other stigmas of hormonal imbalance. They will have more hair growth on their on the facial region. They can have acne and all these things. So that is about polycystic ovaries. So these girls who had developed polycystic ovaries may come into the reproductive age group with similar complaints that the periods are too delayed, or there are in a polycystic woman you can see all kind of abnormal uterine bleeding. They continue to have once the period comes it doesn't stop. They go on spotting, and of course this weight gain and all other stigmas are already there. They also have problem conceiving. So that is the first thing that comes in the reproductive thing. The other thing is because of some structural abnormalities mainly in the uterus, like fibroids. I'm sure all of us have heard about this. So fibroids are of three types. Okay, they are this growth of the muscle mass of the uterus, and the scientific term is leiomyoma, but we are more well versed with fibroids.
Commonly referred to it as.
Yes, commonly referred as fibroids, and depending on where all it is present, so it can be present in the wall of the uterus or as intramural fibroids, or into the mucosal part, the submucosal fibroids, or sitting on top of the uterus as a subserosal fibroid. So depending on where it is, the symptoms come. So the most common ones are which are submucosal or the intramural ones. So these patients, tend to have abnormal uterine bleeding. I think Sri Bharti will explain to us.
Like ma'am has said, fibroid is a very prevalent condition. Around 60 to 70% of our women will have fibroids at some point in their life. They may have single, multiple, a large one or multiple small ones, anything like that. Now, like ma'am has told, depending on the location, they present with symptoms. A submucous fibroid, which is close to the uterine lining, can present with heavy, prolonged menstrual bleeding and cause excessive blood loss during their menstrual cycles. An intramural fibroid, on the other hand, can cause severe dysmenorrhea, what is called as a spasmodic cramping pain that they get during their menstrual cycles. Also, if there are multiple fibroids which are close to the uterine lining and they alter the shape of the uterine cavity, it may also cause infertility, recurrent miscarriages and such symptoms.
Yeah. The subserosal ones are the ones which don't give symptoms very early. But depending on the size, they can also give other kind of symptoms like pressure symptoms when they kind of press on the adjacent organs and all that. A patient with fibroid can also have shorter cycle. She can end up with what we call as polymenorrhea, so bleeding as frequently as every 21 days, and then heavy bleeding, prolonged bleeding with clots, pain. So all that entire spectrum of symptoms can be seen with a patient with fibroids. Now the other reasons for abnormal uterine bleeding could be an infection. It could be an infection or anywhere in the genital tract. These also present with pain during period, pain during a sexual contact. So if we find, if we diagnose that it's due to an infection, it can be treated. The other important reason is what we call as endometriosis and adenomyosis, which are almost two sides of the same coin. Patient with endometriosis generally present to us a little early on because about it is very commonly associated with infertility.
Yeah.
So after a few years of marriage, also when they don't conceive, they come to see a doctor, and then after investigation, she's diagnosed to have endometriosis. But the more clinching point is that her periods are very very painful.
Yes.
So a girl who's having a lot of pain and she cannot go back to her work or attend to her regular things, most often ends up having vomiting, diarrhea, loose motion during the time of her periods, most likely to have endometriosis. And adenomyosis is when similar changes are found in the wall of the uterus. So the uterus is more bulky and there's kind of pain, enlarged uterus. The thing here is that all the symptoms are progressive in nature. That means 1 month if you have a certain amount of pain, the next month you have more pain. The uterus goes on getting bigger in the case of adenomyosis. Sexual contact is very very painful. So these are the symptoms that generally happen with endometriosis and adenomyosis. Yet another structural thing could be a polyp, which is like a simple outgrowth in the inner lining of the uterus. It could be lower down towards the cervix, the mouth of the uterus, or somewhere in the endometrial cavity. They generally present with with heavy bleeding, of course, and intermenstrual bleeding, depending on again the site of the polyp.
They could present with either intermenstrual
Yeah,
bleeding
intermenstrual
or
spotting.
spotting or bleeding after sexual intercourse.
Yeah, if
Sometimes
it's lower
some
down,
erratic
then
bleeding.
yeah, you can. If it's something that is protruding out of the cavities, generally after the sexual contact they can have. Now, beyond this, in the reproductive age group, though it is a little uncommon, but it could also be a cancer of the genital tract, starting from the cervix to vagina to the endometrial cavity and ovaries. So, after investigating them properly, we come to a reason. So these are the general things. Now, by the time we think, the end of our reproductive age group, there's yet another
Towards the
challenge.
menopause.
Yeah, the pre-menopause and the post-menopause. So, most of us have an idea as to when menopause comes and hits us. We think about 48, 50 is when we get menopause. But the pre-menopause or the climactic starts much before this. And all hormonal imbalance, like what was there in the the puberty thing, can again come back here. So it all starts with anovulation again. So the release of egg is not so proper here. So because of the ovulation getting erratic, the hormones get erratic. Now most of these ladies around menopause, how they present to us is with heavy flow. Of course, sometimes they don't have periods for 2-3 months, and when periods come, they are very very
It's a
heavy,
heavy cycle.
and they don't stop.
And they're usually painless cycles.
Yeah, they're painless because there's no ovulation, they're mainly painless. And then when we diagnose them and we see that the lining of the uterus is very, very thick, this falls into the thing of uh, endometrial hyperplasia. Similarly, after attaining menopause, say after 3-4 years, if you again have some kind of bleeding, that is also abnormal. This is postmenopausal bleeding. Most of the time, the reason may be very, very simple, like just some vaginal
Infection,
changes
atrophy.
or infection, atrophy of the vaginal mucosa, all that. But it could also be something like cancer. So we have to evaluate you properly and see. And of course, endometrial hyperplasia is yet another reason why postmenopausal bleeding can happen. Now,
So in that age group, we have to always keep in mind that cancer could be one of the reasons why you're having abnormal bleeding.
in the the advancing age
Postmenopausal
group, yeah.
age group.
Cancer is one major thing. So please don't neglect such a bleeding in the postmenopausal age group. So how do we come to know? How do we diagnose this? Very important thing would be history. The history and the symptoms with which the patient presents. So I think we'll just sum it up. Dr. Shri will help us sum up the symptoms.
So like we have discussed so far, it could be, the symptoms could be in terms of the menstrual blood flow, heavy menstrual bleeding, as what fibroids, endometriosis, adenomyosis, polyps, all of these would cause heavy menstrual blood loss, that the patient is having to change more pads than she used to before, if she's passing clots, or if she has any fainting episodes, if she has required transfusion, or if there is severe cramping pain that she had not experienced before. These could be some symptoms. And like we also discussed, there could be infertility in young couples who are trying to conceive, that these conditions could also cause infertility. Now coming to how we would diagnose, like ma'am has told, it is first we start with history, a thorough history, and then we examine the patient. Conditions like fibroid or an enlarged uterus because of adenomyosis, any cysts, all these can be easily picked up on an examination. So if that does not provide any clue, we can further go ahead to do a scan for the patient.
Scan is a very, very important modality.
Yeah.
For gynecologists, a transvaginal scan is the one which is the best, which will give us
Preferred over an abdominal thing.
preferred over an abdominal thing. So this will tell us about fibroids, about adenomyosis, any polyps, endometriosis, thickened endometrium or endometrial hyperplasia. Besides this, something rare also could be found out on a scan. Very, very important. If we have any further doubt, there are further modes of imaging like a a CT scan or MRI of the pelvis, which can clinch the thing. Now, besides this, of course, something rare like a clotting disorder, all that can be picked up.
Specific blood tests can be done.
Specific blood tests can be done. And also to know about anemia, we can do simple, routine blood tests and know. Also, sometimes liver function tests also tells us about, a malfunctioning liver and deficiency of certain clotting factor and all that. Important here. Now, after this, I think we would want to discuss about how do we treat each thing. So, in the adolescent age group, what do we do?
So, now, like we discussed in the adolescent age group, the common conditions are hypothyroidism, which can be managed by thyroxine supplements, and the clotting disorders, which can be managed by replacement of the clotting factors, those are deficient, and blood transfusions. And coming to the next age group, that is the polycystic ovary syndrome, there are many modes of managing PCOS, but the primary treatment is lifestyle modification. We advise the patients to modify their lifestyle in the sense that they can have a nutritious, balanced diet, and most importantly, weight loss. We tell them to lose around 10% of their body weight over a period of 6 months. And we have seen that majority of the women, that is around 90% of the women, will regain their normal menstrual pattern if they manage to do this weight loss.
Yeah. Besides this, her diet and sleep cycle, all that also plays a role. And there are, if she's having problems like hirsutism, which is excessive hair growth or acne, there's specific medication to treat in this.
Hormonal tablets can also be given to regularize their menstrual cycles and help them conceive naturally if they are suffering from infertility.
Right. So this is about the adolescent thing. Now coming to the reproductive age group, of course, we'll talk about fibroid because which is very, very common. Fibroids, if it's causing heavy menstrual bleed, sometimes even a non-hormonal kind of treatment can also help. So in a very milder form, or someone with a small fibroid having abnormal uterine bleeding, we could either look at non-hormonal treatment or hormonal medicines that can be given. If it is depending on its location, if it's submucosal generally, or it's coming out like a fibroid polyp, then surgery is the preferred thing. Now, surgery could be just removal of the uterus, say if she has to preserve her uterus for pregnancies, or if she's come to us for infertility, we'll do what is called as myomectomy. Now, myomectomy can be done nowadays laparoscopically, and it could also be done by open, full incision and
conventional
method. Yeah. So, removal of fibroids will eventually help her symptoms to get better, will help her conceive, and we can conserve the uterus also. Now, in a perimenopause or a postmenopausal lady who actually does not
wish to retain her uterus, which is completed a family,
we can also look at removal of uterus. That is the preferred surgery. And if she is yet to, there are many years for her to reach menopause, we can think of conserving her ovaries. So a lot of people have anxiety about removing the uterus once we counsel them. So we're not removing your ovaries, we're only removing the uterus. So, you don't really get into that menopausal state. Your hormones are yet
deficiency symptoms are not going to be there.
So you're only going to have it when you actually attain your menopause, that the ovaries will kind of shrink and stop functioning. So about endometriosis and adenomyosis also, again, we could give you hormonal tablets to control your endometriosis, or we could look at a surgery if there are huge cysts or
endometriotic implants can be excised by surgery.
Can be excised. So preferably a laparoscopic surgery is done to kind of ablate all these areas of endometriosis, or to deal with the ovarian cysts that come in place.
Endometriotic ovarian cysts.
Yeah. So now hormonal treatment can be given in the form of tablets, or it could also be given in form of intrauterine
Injection.
device. Many of you may have heard about this thing called Mirena,
Mirena.
or it's a LNG intrauterine system. So it is nothing but something like a device like a property, which all of us know about. But here the difference, it releases some kind of a hormone every day, which is a progesterone hormone. So you don't need to be compliant, remember, and take a tablet every day. What it does, it keeps your endometrial growth in check, and it's a good way of good alternative to surgery. Many of them
Yeah.
respond to this
It's
Mirena
something
treatment.
like in between to an oral hormone intake versus the
Yeah,
surgery.
versus the
The
surgery.
dosages of the hormone that is released are lesser compared to oral intake of the same
Right.
hormone.
So most of the patients, they do very well with Mirena. It could be used if the uterus is not too enlarged, or the cavity of the uterus is more or less regular. Then we can prefer to do put this. It is a one-time thing. Once you put it, it will be functioning for about 10 years, and it gives you birth contraception advantage also for about 5 years. And it is put in very much like how we put a property. In the OPDs, is a small procedure. And the thing with Mirena is that there could be some irregular spotting as a unwanted side effect, but the amount of that heavy flow comes in check, and plus after it can also induce something like no
State of
periods,
menopause,
yeah,
yeah,
a
something
state
like
of
that.
menopause. But still, you are not all the hormones are still getting
It's just
released,
that the
and
blood loss has stopped.
blood loss has stopped, and it really helps patients with abnormal
Yeah.
uterine bleeding. And we should not erratically use hormonal pills, especially towards the older age group, like beyond 40. Now, I think if it's something more rare, like say cancer of the
Yeah.
thing, then each one, depending on what cancer has been diagnosed, the treatment will differ. But the modalities of treatment are generally surgery,
We
chemotherapy, and radiotherapy. Uh, so, to brief it up, or to just tell you about the crux of the thing, is that one should not ignore abnormal uterine bleeding, and not sit back at home and think that things will get better. Most of them are due to a reason, and we can evaluate you and treat you accordingly.
Yeah.
Anything else that we missed? I think that's about.
So you should know when to approach a gynecologist. If you're having any of these abnormal symptoms, please do approach a gynecologist and we can evaluate and treat you accordingly.
Yeah, I think that brings us to an end of this talk. Do we have any questions or anything coming? We'll be glad to answer. Is there anything that